It's been a long day and a half, and I'm obviously not going to go over everything that we've said in that day and a half, but I wanted to touch on a couple of points. And one of them is that if our last day and a half is to have been worthwhile, then this needs to be the beginning of something, not the end of something. So that, producing a book, which we will do, and a dissemination paper, which Sam Takvorian and others will write, will be good things to have happen. But we need to take the lessons that we've learned over the last day and a half and try to figure out how to move them forward. So I just wanted to put this back up again to emphasize two things. One is at the center of all this work, as many people have said, there is the ideal patient experience. And for all that we do, it's been said over and over again, let's not forget that we're doing all this because there's a patient and that patient has cancer and we're trying to give them the best care possible. But we also have to be realistic about all the stuff that's going on around, because if we aren't, then we won't be able to help. Let's also be realistic about the data. And my concern is that, year after year, we just work harder. We just figure out how to get the patients in to be seen and get them treated. But for those of us who have done this for a long time, it's getting to be harder and harder. And I think we need to look at the facts. And as Otis went over very carefully yesterday, though incidence and mortality is decreasing, which is very good news, though obesity is sending some of the arrows in the wrong direction, the reality is that the total number of patients requiring care is going up, and it's going up substantially, and will continue to go up for the foreseeable future. And it's not just those that are being cured, but even the extending of life, which is great, means that we're caring for more patients. And in a very crude numbers way, I always think, if you see 100 new cancer patients a year, lung cancer patients a year, and their survival is 1 year, which is what it used to be, you're caring for 100 patients a year. If that survival is now 2 years, which is closer to what it is now with some of the new immunotherapies, that same 100 patients a year is now resulting in 200 patients that you're trying to care for. So changes in survival, which are great, also add to this. And the number of providers may be going up, but not very fast. And I showed you this, and I'm not going to go back over it, but I will say that after the last day and a half, I don't see anything to add to this slide. I don't see any other multiple choice answers that you could choose from. And so it seems to me that the major issue is we do need to figure out how to practice better. And remember that the title of this workshop has two pairs of words. One is developing and sustaining. Okay, so we need to develop new models and sustain them for an effective and resilient care force. So keep those in mind. A lot's been said about the culture of our practice, and I would argue, as I think I mentioned yesterday, that these are things that are in our control at the local level. They don't have anything to do with, what CMS is asking us to do or many other aspects of our practice, and I think Bob and Tony Back and others outlined a lot of this yesterday, but we can change the way we think about how we do our work. That has to come through leadership. It has to come through teamwork and a whole different way of thinking about things that some of us do think about. And I would say that we need an ecumenical practice structure. We've, in medicine, had a long tradition of hierarchical practices. It used to be worse. It's gotten a little bit better, but probably could be better than it is now. And over again, we heard that the only solutions really involve teamwork. And so, who is on the team? And how do you put all these people together? And I've just listed some of the people who may be on the team: physicians and APPs and RNs, navigators, survivorship follow-up professionals, palliative care professionals, and then down a few lines, the patients and the caregivers as well. But how is a practice structured? Are we going to continue to practice like most of us do? Or are we going to think about new ways for us to practice as a team? And again, I think, somebody made the sports analogy yesterday, and I often use that because I spent 15 years working for Ed Benz, and he uses football analogies all the time. So, it's sort of born into my cortex. But, you have a team. The only teams that win are teams that have players that have different skills in different positions, and that you know how to use those skills in an organized way. And it's not hard to understand why that's complicated. But I once wrote an article in JNCI about how in the VA system, tumor boards did not improve the outcomes. And then Doug Blaney wrote an editorial that said, every football team does a huddle before their next play, but some teams win and some teams don't. And what it is what happens in that huddle and how you execute. So having the huddle itself doesn't help. It's really how you organize yourself in that huddle and play. So how do we improve the patient experience and the provider experience? And I would argue that they will go hand in hand, that we have the opportunity to improve the way we deliver care, which will make us a happier, less burned out profession with greater satisfaction, and patients will be the beneficiaries of that because the type of care that they receive will be more attuned to what they need, and it will reduce frustrations for both patients and providers, and we've heard some examples of this. But how do we change our practice model? And so, I made the comment during the last panel that there were lots of good ideas, but I think there weren't as many ideas about how to move from A to B to C. How do we actually implement these ideas and how do we get to a better place? And maybe some of the participants here should think about writing a paper that focuses on this. I think that would be a good thing to do. There are some outside forces, and I'm not going to spend a lot of time on this. I will say, EHR usability can be better. I wanted to thank Matt from Epic, who sat here very politely and diligently over the last day and a half, watching and taking notes, and sometimes hearing things that probably hurt his ears. But how do we make sure that the vendors, the EHR vendors, are our partners? And I think that really can happen. A lot of what they've done has been a reaction to things that are out of their control and out of our control, to do with billing and other compliance issues. But how can we turn that a little bit so that when we go to clinic, the data that we need to care for a patient, whether it's genomic data or other data, is easily at hand. It is a complicated place. And I remind my own faculty that, Epic is not solely an oncology EHR. Cerner and the others are not as well. They have to take care of obstetrics and the ED and lots of other specialties. But I'm a selfish, myopic guy, and so how can we make it work better for the oncology providers? We heard a lot about interaction with the payers, whether it was CMS or Aetna with Hal Paz, and we appreciate both Ron's comments and Hal's comments. But I think we got to do a better job of what we're doing. And right now, we're in a system that I would say is, just broken. It's a dinosaur system. It has a huge administrative burden, not only on the providers, but frankly on the payers as well. When we're sitting there arguing about whether some patient should have an MRI scan, there's somebody on the other end of the phone line at the payer who's answering that call and spending time on that issue as well. And I do believe that there are better ways. I think there are ways that we could automate to a large extent pre-authorizations and in some degree eliminate them. And we talked a little bit about the alternative payment models, and I pestered Ron a little bit about how hard it is, I think, to do this broadly in oncology. I would personally agree that that's one of the answers to being in a better place, but I'm not quite sure how to get there, and I think that's one of our challenges. But we have to look very, very carefully at what we've learned from the oncology care model, which I think has been a great experiment, but also has a lot of lessons. And we need to know what those lessons are, and Hal described Edna's oncology medical home, which also has been an experiment with lessons. We got to catalog those lessons to try to figure out what the next best way is. And we've talked a lot about technology, and I'm not going to go into this in detail either, but I just can't help but feel like we are way behind in how we use technology overall. And just think about the rest of your life, whether it's how you do your banking, how you deal with Amazon, and how those functions have changed the way we live our lives. And I just keep feeling like, we're back to the early 1980s when I bought my first PC, trying to figure out how to use it. Technology is not a standalone. I think it's a partnership with the human beings who still are part of the care team. And that's one of the ways that we should think about it. And it's certainly how Penny and Robin and some of the other technologies work. And I think viewing it that way is very helpful. There have been some technological experiments where they've tried to get computers to replace the care team, and I think those have largely not been successful. So think about it as a partnership, another member of the team. And one of the things Sam didn't mention during the Penny presentation yesterday was sometimes our patients forget that Penny is actually a bot and not a person, and Penny checks in on Monday morning and the patient asks Penny how their weekend was. And there were also some very interesting interactions last winter when the Philadelphia Eagles were in the Super Bowl about that as well. Penny wasn't quite sure what to do with those comments since they're not, commonly, chemotherapy toxicity related. And how can we use technology to better support patients and their caregivers and improve efficiency? So again, keeping this in a sharp focus. So, I started yesterday by talking about the 2009 workshop that we had, and maybe it occurred in 2008. The book came out in 2009. And that, if anything, from my own point of view, in those succeeding 10 years, the problems have become more severe, not less severe. So Winston Churchill, again, who's one of my heroes, said success is the ability to go from failure to failure with no loss of enthusiasm. So we've had some lacks of success over the last decade, but I would say we need to continue to be enthusiastic. And he had another quote that said, difficulties mastered are opportunities won. And we have lots of difficulties that have been outlined over the last day or two, but I think that they need to be focuses on, in fact, how to turn them into opportunities. So where now? We need to remember that we live in a world where all change is to be resisted. One of my neurology friends told me a story, is that if you keep your car keys in your right pocket for, decades, which I have done, if you put them in your left pocket going forward, how long is it going to take you to remember that they're in your left pocket and reach into your left pocket and not your right pocket? We've become creatures of habit, and that's what we're comfortable with, and even changing some of the very simple things that we do is not so easy. And there's an inertia, the turning the battleship, and there's also this discoordination of sources of revenue and streams of expenses, which might get better with a truly broad alternative payment model and bundled payments. But right now, it's the world we live in, where I might want to hire more navigators, but that comes out of one pocket. And is that really going to lead to revenues down the line that I can prove to my health system are a benefit and make it worthwhile to hire those additional navigators? But I do feel that if we don't change and we don't find a better way, both our patients and their caregivers and us as a profession will suffer. It's going to become harder and harder to meet the needs of the patients and deliver good care in the way that we would like to without even worse burnout than we have. And I think that it is ultimately up to the collective us. And so what I would suggest to the people who have participated in the workshop is lots of good ideas were laid down, lots of good ideas will end up in the proceedings book. But our challenge now is to try to figure out how to do some implementation experiments to see how these things can actually happen and how they can be scalable and sustainable. Otherwise, the experiments will be a futile waste of time. So I think that is our next charge, and I want you all to think about that hard. I just wanted to thank the planning committee and my co-chair, Lisa. There was a lot of work that went into planning this workshop, and we're very appreciative for the dozens and dozens of hours of phone calls and backs and forths on emails, and also especially to thank the staff who are listed here, so I'm not going to call them all out, but without them, this workshop wouldn't have happened, obviously. And it's almost as hard a challenge as fixing this problem, hurting a bunch of cats like myself and my colleagues to keep focused and have us have really a productive workshop. So thank you all, and keep thinking, and let's not drop this. And a special round of applause for the staff.